Hi, this is Dr. Bernstein with our September 2016 Teleseminar. This time round we have no special subject because we have a large backlog of questions that I'd like to get to. So we'll start right off with the first question. Why do some people with low hemoglobin A1Cs, less than 5.3%, get complications? That's a good question. I don't know where you got this information from, but it really depends on how long the A1C is elevated. 5.3 is not low relative to our ancestors. If we look at the people from whom we've evolved over the eons, people who had no agriculture, who had no sugars, could not get sweet foods, they probably were walking around with A1Cs between 4.2 and 4.6. And we do know from a number of studies that the effects of glucose on many systems of the body, including the brain, is a continuous one. That is, a slightly high blood sugar has slight effect, adverse effect on many systems, and a higher blood sugar has a higher effect, etc. So 5.3% is a little above ideal, and one would slowly, over many years, be expected to develop diabetic complications. But people with 5.3% are going to have a much better time than those that have the 6.5 or 7% that the American Diabetes Association recommends. The difference in average blood sugar between, say, 7% and 5.3 is 5.3 is an average blood sugar of about 112, and 7 is about 180. So that's quite a difference. By the way, I might add that several studies have shown that in non-diabetics, the lowest mortality is with an average blood sugar of around 83. Next question. Would following your suggestion of a high-protein, low-carb diet have a negative impact on cardiovascular performance in sports such as boxing? I would think just the opposite. You need protein for muscle mass, and carbohydrate doesn't per se do anything for you. The only time it would be of value would be during an activity. For example, if you're, this person's asking about boxing, if you're boxing over the course of an hour, even if you're non-diabetic, if you're really doing it strenuously, you're likely to use up all your stored glycogen, so you'd be wise to be consuming glucose beverages over the course of that hour. So that's where carbohydrate comes in handy, but not slow-acting carbohydrate, rapid, for the activity while it's going on. The protein is essential for building muscle. If you don't consume much more protein than a non-athlete would, you're not going to build muscle. In fact, I remember long before I became a physician, when I started working out in the gym, I got a craving for protein. I didn't know why that was. I was not a physician, but it's now very apparent that you need that for building muscle mass. Next question. Is an A1C score of 4 too low? Is there a number that would be considered too low? I would not go by A1C score. I'd go by blood sugars. there are lots of things that affect A1C in addition to blood sugar, things like hematocrit and so on. So I would go by blood sugar, and I would say that for adults, an average blood sugar of 83 is good. If you're not diabetic and you, after strenuous activity, go down to 70, that wouldn't do you any harm. It would probably come up in a while. For diabetics, you want to keep your blood sugar at a level where your cognition and coordination are not adversely affected, just in case you're a driver or operate machinery. So if you go down to 70 or 75, you want to bring it up to around 83, which appears to be ideal. But I wouldn't go by A1C. Not only that, different labs have different normals for A1C and even different values on the same individual. There are A1C test kits that the labs use, and one manufacturer's test kit might give different results than another's. So go by blood sugar rather than A1C. Next question. Type 2, 63-year-old female. A1C is 8.1%. Says, on your diet. Well, it's pretty hard to believe that she's on my diet if she has an A1C of 8.1%, which is an average blood sugar of something like 220. Takes extended release metformin, Levemir at bedtime, which she says causes insomnia. I also need Lantus. I need the Levemir for the dawn phenomenon, but I need my sleep. Any suggestions? Well, first of all, I'd suggest that you read my book, because with an A1C of 8.1%, you probably have nocturia. You're probably peeing all glucose away all night. So that's one suggestion. Another suggestion, if you're using insulin, would be to use Tresiba insulin, which we discussed in the last teleseminar. We give it twice a day on a rising and at bedtime, and it seems to last fully overnight, unlike the Levemir and the Lantus. So that's basically it. Read the book and look into Tresiba insulin. Next question. Diagnose type 2 with an A1C of 9.7. On your diet and take 500 milligrams. Oh wait, one more thing for the last question. That lady is taking metformin, and we find a tremendous difference between generic metformin and Glucophage, the brand. So I recommend to everyone that they switch to Glucophage. You know, it's interesting, I've been making this recommendation for years, and I still don't know who manufactures Glucophage. I know that we tried to get samples for our patients and they wouldn't give it to us. So I don't even remember who manufactures it. They have no influence on me, but it's the version of metformin that's really effective. There's a big difference between that and generic. Anyway, this next question. A1C of 9.7, takes 500 milligrams of metformin twice a day. Last A1C, 5.6 is the lowest it has been. Should I increase the metformin? Will my body develop a dependency? A dependency, I don't even know what you mean. There's something that addicts to certain substances develop a tolerance where you need a higher and higher dose. A dependency would mean that if you stop it, you get side effects or adverse effects. If you're controlling your blood sugar with the proper brand of metformin, and your blood sugars are normalized, and then you stop it, well, your blood sugars are going to go up, so you're dependent on it in that sense. The one recommendation I would recommend here is that you switch to the brand name Glucophage, and you'll probably find a big difference. And again, that's in my book, so I'm wondering whether this person really read the book carefully. The book's name is Diabetes Solution. I'm a 71-year-old male with A1Cs of 5.6 to 5.8 over the past 3 years. I've been on your low-carb diet for a week. My average fasting blood sugar, 95 milligrams per deciliter. My average 2-hour post-meal blood sugar, 105. Not on any medications. Should I consider myself pre-diabetic? What can I do to get my blood sugars to 85, or is this not a reasonable goal? Well, first of all, I'd recommend that you read my book, Diabetes Solution. That gives step-by-step the things that you take if step 1 doesn't totally normalize your blood sugar. It goes to step 2. And step 2 might be weight loss, it might be physical exercise, strenuous exercise, or it might be glucophage. But look at the book, it's in there. We are trying to reduce postprandial glucose levels of my 11-year-old daughter. She regularly goes up to 15 millimoles per liter, which is 220 milligrams per deciliter, and one piece of toast starting from after one piece of toast, starting from 5 millimoles, which would be about 90 milligrams per deciliter. So she goes from 90 to 220 from one slice of toast. We have lately tried only giving her one fried egg and bolusing on her insulin pump for half an exchange. She still goes to around 12 to 15 millimoles. Well, 15 would be, you have to multiply by 18. It's close to 300 milligrams per deciliter. Okay, read my book, Diabetes Solution. You're doing everything wrong. Insulin pumps don't give predictable results. There's just no way with giving her a toast. I would never give a diabetic toast. I haven't had a piece of bread since around 1970. So read the book Diabetes Solution. You're in the same ball game that Dave Dykman Jr. was in. You might look to his website, go on Google to type 1 ONE grit, and you'll see the before and after. He was doing just what you were doing, insulin pump, toast, and all that, and was totally out of control. And then they read my book, and everything changed. Next, is there any risk to my 12-year-old type 1's health who is underweight? Let's see, what's her weight? About 61 inches tall, and her weight is 101 pounds. Is there any risk to radically change his diet to your program? Don't want him to lose weight. Well, I about 6 months ago, had a kid about that age whose main problem was failure to grow and failure to gain weight. And all we had to do was normalize his blood sugar and increase his protein intake. We also had to increase his insulin to cover the extra protein, the additional protein that he was getting. So by being on my regimen, kids tend to grow and put on weight, whereas when their blood sugars are elevated, they tend not to grow and to not adequately gain weight. So again, read my book and do what it says if you want your kid to grow. You could also check on a very old article by William Tamberlane going back into the 80s, where he looked at growth curves of children who were diagnosed with diabetes. Their blood sugars went up, and they dropped way below their normal growth curve for both height and weight. And then when their blood sugars were controlled, they went back to their old curve. That's in the literature, and there may have been other studies since then. What is the best way to start the low-carb diet? Best way is to read the book, and the book advises you to do it instantly, not gradually. But when you do it, you have to lower medications frequently, dramatically. But it's all there in the book. Diabetes Solution. Diagnosed with autoimmune Graves' disease in 2009 and a typical type 2 diabetes. What are your thoughts on SGLT2 inhibitors? I was placed on Invokana. I was in ICU last week for 4 days with a euglycemic diabetic ketoacidosis. Well, Invokana is a class of drugs called SGLT2 inhibitors. These are things that cause you to pee away glucose. Well, they lower the renal threshold for glucose, which means that where a normal person or even a diabetic might start peeing substantial amounts of glucose in their urine with a blood sugar of 165 or 70, it might lower it to 120, so that when your blood sugar is 120, you start peeing away a lot of glucose, thereby lowering your blood sugar. There are a host of potential adverse effects from this because it can dehydrate you, can cause problems if you have kidney disease already. And the medical profession has erroneously called a syndrome that this can cause, diabetic ketoacidosis. Well, diabetic ketoacidosis is caused by severe dehydration compounded with very high blood sugars. Here, with this stuff, you get severe dehydration and ketoacidosis without high blood sugars, so it's not caused by diabetes, it's caused by the Invokana, which has caused severe dehydration. So it's misnamed, and the whole medical profession and all the diabetes associations are calling it by the incorrect name, but it's caused by the Invokana, and this would happen in anybody, even if they were not diabetic, if they were greatly dehydrated. And the answer to that problem is that you have to consume a lot of fluid if you're taking Invokana. And if you're taking Invokana and have high blood sugars to begin with, you have to consume huge amounts of fluid because you're going to be peeing away huge amounts of fluid and potentially getting dehydrated. Our daughter diagnosed type 1 at 7 years of age. She's now 31 and is a doctor in Ireland. hoping to specialize in cardiothoracic surgery. However, her sugar levels for the last year have been uncontrollable. As a result, she now has diabetic retinopathy. Last week she had a bleed in one eye and is having more laser treatments. Her eyes are a critical element in her career. Any suggestions? The main suggestion is normal blood sugars, which she probably knows. And the thing is that most doctors don't know how to get normal blood sugars, and certainly they don't bother to read my book because doctors don't read books. They don't have time. But your daughter certainly should read my book, Diabetes Solution. It's available in Ireland. She could get it over the internet. Amazon has it. Barnes & Noble has it. It's easy enough to get, and it teaches you how to normalize your blood sugars. There is one warning. If you already have retinopathy, you should get your serum IGF-1 level checked. IGF, insulin-like growth factor, number 1. It's a growth hormone. If that level is high, then your blood sugar should be lowered very slowly if you already have retinopathy, because it can get worse with the lowering blood sugar if it suddenly drops. This is as per an article by Ernst Chantelau I believe it appeared in Diabetologia a few years ago. So it's important to first check IGF-1. If it's not elevated, you normalize the blood sugar as rapidly as possible. Could you discuss the connection between anemia and A1C value? Okay, I hope I get it straight. There are two kinds of anemia. There's macrocytic and microcytic. In microcytic anemia, your system is making new red blood cells at a rapid rate, but they're not of normal size. And their lifespan is limited. In macrocytic anemia, usually due to not enough B12 or folate, the cells don't reproduce fast enough, and they keep growing, and therefore they're exposed to glucose for longer periods of time. And since when the hemoglobin is exposed to glucose, it gets glycated, and you get glycated hemoglobin, which is hemoglobin A1C. So these older cells, when they're lysed to measure glycohemoglobin levels, will show a higher glycohemoglobin. So macrocytic anemia should show a higher glycohemoglobin level, and microcytic anemia should show a lower level. That's about all I can say right now, but there's probably a lot more to it, because hematocrit may have an effect, and so on. But I haven't boned up on this lately. I'm just going on what's in the back of my head. I'm a skinny type 2 diabetic. I use 750 milligrams of metformin, and again, we don't know if it's brand or generic. For most people, it's generic, which is unfortunate. And between 1.5 and 2 units of regular insulin per meal. Neither my GP nor endo is willing to prescribe me anything since my A1C is 5.0. In other words, the ADA wants you to be over 6.5, and depending upon your age, over 7. and even over 8 if you're my age. So if this person has an A1C of 5.0, the doctors are afraid to treat her. I know my blood sugars stay between 70 and 100 during the entire day, but during the night they increase from 95 in the evening to 125 in the morning. I only have access, I can only access OTC, regular insulin, and regular NPH. So this person in her state or country can purchase on her own regular insulin or NPH. What would you recommend to get my blood sugars under control during the night? I know that NPH has serious drawbacks as mentioned in your book. Well, it doesn't have serious drawbacks, it's just that it's not really a long-acting insulin. I'm willing to get up once in the night, middle of the night, to give a second small shot if required. Okay, this, I have several bits of advice. Number one, because NPH is relatively short-acting and tends to have a peak 8 hours down the road, it may be ideal for an overnight shot. So you start with maybe a half unit at bedtime, and it might do the job, or you might have to increase it to a unit. You might have to check your blood sugar during the night, the first few nights, to make sure you're not going too low, but that's one solution. The other solution, which you should also follow, is to dump your 2 current doctors and find yourself a kindly family care doctor who will be more cooperative. And in my experience, the best way to find such a person is to ask your friends or neighbors, do they have a kindly family care doctor who relates to patients in a productive fashion rather than a destructive fashion? Next question. Insulin pen inserts, I guess package inserts, all state that syringes should not be used with insulin pens. Is there any real reason not to use syringes with insulin pens? I find that syringes are better able to control doses, such as less than 1 unit of insulin. I'll explain what this person is talking about, and this is a very wise question. Some of the insulin pens are provided with replacement cartridges of insulin, so that you could either use the pen to deliver the insulin, or if you want to go to the trouble, you can take an insulin syringe, stick the needle in the stopper of the of a single cartridge that's not in the pen, and draw insulin out of the cartridge directly into an insulin syringe. And if you're using one of the syringes that has half unit markings, you could actually draw out a half unit or 2.5 units, and you can even estimate quarter units, so you could get an estimate of 3.25 units, whereas with the pens, most pens will only go to the nearest whole unit, and some pens will only deliver to the nearest 2 units. So you could get more accuracy. Now, you have to be careful of 2 things. The cartridges have a gasket at the opposite end from the stopper, from the diaphragm that you puncture. And this gasket moves when you draw out insulin, but there's a lot of friction. So you have to pull on the plunger of your syringe very slowly, or that gasket won't move, and you'll get air in your syringe. The air will come out the back of the syringe because you're creating a vacuum. So And you also must stick the needle in the very center of the diaphragm, because the diaphragms tend to be very thick at the periphery. So you have to you have to have good eyes, you have to find the center of the diaphragm, puncture it there, and very slowly draw out the insulin. And indeed, this can give you more accuracy. Now, if you're an obese type 2 diabetic and take huge doses of insulin, that degree of accuracy may not be important. But if you're a small person like me or a child, it makes a big difference. My urine pH is 5.5. pH is a logarithmic measure of hydrogen ion concentration, which is inversely related to acidity. The higher the pH, the less acid the urine. So my urine pH is 5.5. Is this a concern? How can I raise the pH of my urine? I'm a type 1 on low-carb diet. Well, a normal pH is 4.6 to 8. So you're pretty much near the middle of normal. My question is, why on earth are you measuring the pH of your urine? Now, I know that there are a lot of charlatans on the internet who are telling patients to check their urine for ketones even when their blood sugars are normal, telling them to check their urine pH. They're worrying about their body acidity. They want them to take acid cleansing diets or machinery or whatever. There's no reason for people to look at their urine pH. If you had a kidney problem, then your doctor should be looking at a variety of things that would include pH. There may be some bizarre medical conditions unrelated to diabetes that have to do with urine pH, but for a diabetic to routinely look at urine pH, that just doesn't make any sense. It's just like if I were to look at my urine for ketones. I know that if I don't, I frequently skip meals because I'm very busy. And if I don't have dinner and I get up tomorrow morning, I'm sure to have ketones in my urine. I'm not going to test for it. This is normal. This is part of being human. Anyway, your pH is normal and you should stop looking at it. I have a dawn phenomenon as a result of my type 2 diabetes. My blood sugars used to raise anywhere from 70 to 100 points overnight. I have found that if I take one Excedrin migraine gel tab in the evening at bedtime, my blood sugar either does not rise at all, decreases, or rises minimally. Is there something in the pill that remarkably controls and or eliminates the dawn phenomenon? It contains acetaminophen and caffeine. Well, it also contains aspirin. And we do know that aspirin can paralyze the liver, as can acetaminophen, if given in a large enough dose. And that prevents counter-regulatory behavior by the liver. In fact, I remember many years ago, before I became a physician, I had severe shoulder pain. It turned out to be diabetic frozen shoulder, which was subsequently cured many years later. But my wife, who is a physician, said, take an arthritic dose of aspirin. I said, how much is that? And I think she told me to take 2 tablets every 4 hours. And I ended up having severe hypoglycemia that knocked me unconscious, and continued to get multiple hypoglycemic episodes for 2 days because my liver had been paralyzed and could not help in counterregulation. So since the liver does play a role in the dawn phenomenon, namely it clears away insulin in the early morning hours, it could be that this combination of aspirin and acetaminophen may indeed do the trick. Now, is that the answer to this phenomenon? Well, maybe. I don't, if it works, it works. What I do with people who take insulin is give them Tresiba insulin, which for most of us lasts overnight, and we take it at bedtime. Most of us must also take another dose in the morning to cover the daytime. My 13-year-old son has a follow-up visit with his endocrinologist, who has been treating him for precocious puberty with human growth hormone. His lab showed a hemoglobin A1C of 5.4. After listening to your December webcast, you mentioned anything over 5.0 should cause concern. The doctor said it was probably because of puberty. Should I be concerned? Well, my guess is that it's probably because of the growth hormone, and maybe your endocrinologist would be wise to give him metformin to bring the A1C down. There is some evidence that in mild diabetes, like type 2 diabetes, glucose toxicity can make the disease worse. Well, it's also evident in type 1 diabetes, early diabetics, that if their blood sugar is high, beta cell destruction is going to accelerate. So even if this kid is not diabetic, why expose him to high blood sugars? And there's a good chance that glucophage, I shouldn't have said generic metformin, it's glucophage, should help his situation. It's not that it's an emergency situation, and my guess is that it's the growth hormone that's doing the dirty work. Are there specific exercises that a diabetic can do to lower blood sugars quickly? Well, it's been known for years that if you give an injection of rapid-acting insulin in a muscle and then exercise that muscle, you'll accelerate the absorption of the rapid-acting insulin and therefore accelerate the drop in blood sugar. In my experience, the type of exercise that most rapidly reduces blood sugar, forgetting about injections, just where the exercise itself, by moving GLUT4 glucose transporters to the cell membranes where they bring in glucose and lower blood sugar. The exercise per se does that. Cardiac exercise, that is exercise where you get your heart rate very high, works the fastest. And this is not recommended for someone with a heart condition, but if you're young and in good physical shape, you get your heart rate above the theoretical maximum, and that has the most rapid effect on the one hand. On the other hand, if your blood sugar is already significantly elevated, let's say it's over 160 or so, the exercise can raise the blood sugar. So there may be a contraindication to using exercise to lower blood sugar if it's really high. What if your blood sugar is 125 and you want to get it down to 80 or 83? This kind of exercise is the most rapid-acting kind. Now, there may be some sports that are just as effective. For example, prolonged boxing might do it. By prolonged, I mean for an hour or so. Again, there may be soccer, if there are no breaks, can also do it, and so on. Are you still recommending Levemir as your choice for a basal insulin? Well, for most people, I've graduated to the newer insulin Tresiba because Levemir does not usually last the night. First of all, both insulins you take twice a day, in the morning and at bedtime. Although I've seen some type 2 diabetics who only needed it once a day. And I do have some type 2s who get a small dose of Levemir in the morning and nothing at night. They don't have the dawn phenomenon. But for type 1s, I would prefer Tresiba. We have almost all our type 1s now on Tresiba, simply because of the dawn phenomenon. Who's the best doctor to conduct an RR interval study? My internal medicine doctor, endocrinologist, or a cardiologist? It would be the doctor who knows how and who is willing to do it. It takes time. None of these doctors do this study routinely. Except in my office, it's a research study. I do it on every new patient because I consider it essential. But this has not sunken in. It's amazing that I actually did get an article published in the journal Diabetes Care that instructs one how to do this test. We are planning to do a video on this. A couple of physicians are coming in here in a month, and they're going to film my doing an RR study with instruction, and we're going to put that up on the internet so that any doctor can learn from us. It's a pretty simple thing to do, but you have to follow the protocol that I use very carefully because it's easy to make mistakes. It's unlikely that you'll find a doctor who can or is willing to do this, but a cardiologist in a research institution may already have a setup for this for his research studies. So that would be a possibility. The only other possibility would be an endo or a family practice doctor who is himself a diabetic and is interested in learning to do an RR study because of his great interest in diabetes. I am a diabetic who takes Novo Rapid to cover most meals. I want to use your diet now that I am taking insulin. I have read of various different formulas for counting net carbohydrates, and you can deduct the fiber and sugar, alcohols from the carbs in computing insulin requirements, and etc. And he goes through numbers and says your thoughts. This person clearly has not read my book. I cannot possibly control blood sugars by changing the amount of carbohydrate and protein from one meal to another. That guesswork just doesn't work. I have constant meals for myself, and when I get bored with what I'm eating, I'll change to another. Let's say that my breakfast right now is sardines and Limburger cheese and a few pistachio nuts. Now, 2 years ago it was something totally different. And 4 years ago, I think it was bacon and eggs, or it was soy bacon and eggs. So I change when I get bored. But then I keep it constant because it's a matter of trial and error to get the insulin dose right for the meal, and also to get the insulin timing right for the meal. Now, in my book, we tell you how to do this for the first meal, but then you're going to be off. You're likely to be wrong, but not by a huge amount. And then the second time you do this, you make adjustments in the insulin dose based on your mistake. And eventually you'll get it just right, and you repeat that dose for that meal thereafter until you get tired of that meal. So this person doesn't comprehend the whole approach. Now the other question is NovoRapid. I don't recall whether NovoRapid is the same as Novolog in the USA. And Novolog is too potent for most people. 1 unit of Novolog will lower my blood sugar by 90 milligrams per deciliter. So it's hard to get a precise dose. Whereas 1 unit of Novolin R, which is regular insulin, will lower me by 60 milligrams per deciliter, which is still hard to manage. And in theory, I should be using diluted regular insulin for precise tuning. So if NovoRapid is the same as Novolog, it's too potent for me for low carbohydrate meals. Also, if you have gastroparesis, it works too fast. So there are lots of potential problems. Next question. I am 71 years old, weigh 5 foot 2 inches, 104 pounds. Fasting blood sugars hover around 100 to 107. Recently my A1C was 6.0, which by the way is an average blood sugar of 140. So this person probably is not checking her blood sugar after meals, which is the most important time to check. I have avoided sugar for years as it causes me to get a sore throat and colds. I take Armour Thyroid. I have now started avoiding carbs. Should I be concerned? Well, sure. Again, it depends on how long you plan to live. You're 71 years old. If you're planning on living 20 years, I'd say you should be very concerned and should seek normal blood sugars. But if you're planning to live 4 years, I don't think it's going to make much of a difference. If you want to normalize your blood sugars and get that 6.0 down to a 4.6, read my book, Diabetes Solution. And certainly you should be checking blood sugar. If you're looking at blood sugars, it should be about 2 hours after your meals. And if you're hypothyroid, you should use the guidelines that we have in my book, Diabetes Solution, about using T3 for the purpose of treating low free T3 levels. Armour is a combination of things of T3 and T4 that's sort of hard to control. I like to treat T3 and T4 separately by using levothyroxine plus slow-release liothyronine. Let's see what else we got. I've read that if you eat a very low-carb diet, that your fasting blood sugar can slowly creep up over time, and that numbers in the 90 to 100 range are normal. Is that true if you are not diabetic? I don't think it's true. I don't know where you got this from. There's a lot of nonsense out there on the internet, and people are constantly being bombed with BS, and that's about all I can say. What is your opinion of the work of Dr. Jason Fung, a nephrologist from Toronto who advocates fasting as a way to decrease insulin resistance? I am currently following your teachings of low carb, but would like to add intermittent fasting. I am very careful to regulate my insulin and check my blood sugar. Okay, first of all, if you're using my insulin regimen, where you only take insulin, where you take basal insulin plus bolus insulin for meals, if you want to fast, you don't take your bolus insulin for meals. If you need corrections, you take boluses for corrections. So it's certainly possible to fast on my regimen. And I remember when I was an intern, and even in my third year of medical school, I sometimes was so busy on the wards that I didn't have time to eat for 2 days. It was not a catastrophe. There's no problem. As far as Dr. Fung goes, I don't know anything about him. I don't have the time to look him up. But it reminds me of a standard warning that I give when it comes to authorities on the internet or even on television. Beware of the following. If the person acts like an actor rather than a physician, be suspicious. There are a lot of doctors who are performers and are trying to convince you of something that may not be valid. That's number one. Number two, be very leery of anyone who's trying to sell things. Well, you could say that applies to me because I'm trying to sell my books, but if you saw the statements I get, I don't make very much money on them. And the royalties get split up between a literary agent and so on. So I'm not making a fortune on my books, but there are plenty of doctors on the internet and on television that are selling diets, food, supplements, etc. Be wary of that. That is a high index of suspicion. If they tell you something that's too good to be true, don't believe it. There's no magic out there yet. It's, as far as diabetes goes, it's a lot of hard work and sacrifice. And you have to be very determined to do the kind of things that I do or that the people on Type 1 Grit do. We get results, but it takes an effort. And to think you're going to get magic, it's not going to work. Now, will fasting lower insulin resistance? I doubt it very much. I've had some patients who fasted, and one of them's wife was into this and convinced him to fast, and he found that when he fasted for a week at a time, his craving for carbohydrates diminished. But then it came back after a few weeks. So be wary. But again, it's not going to kill you. What is the best way? Wait. I have heterozygous familial hypercholesterolemia and report very high lipid levels. On the low-carb, high-fat diet, even with limiting saturating fats. I have a history of heart disease in my family. I have followed my lipid levels by taking Lipitor, but I'm experiencing negative side effects from the medication. In my case, do you think it is acceptable to consider staying on statins, or do you recommend any other options? Yeah, there are a number of other options. First of all, I would check your serum-free T3, because low T3 can in and of itself cause a dyslipidemia, and it could be that your whole family has a history of low free T3. That may or may not be the case. Then I'd look at triglycerides, C-reactive protein, lipoprotein, small a, and other markers of inflammation. And if you have high inflammatory markers, some anti-inflammatory drugs or supplements may be of value. Very important would be to get the 3 imaging studies that I frequently recommend to see if you have atherosclerosis. It could be that, like many of my patients, you may have a calcium score of 0, in which case you certainly shouldn't be messing with statins if they cause adverse effects. So the 3 studies which I've mentioned before are calcium score, coronary artery plaque density, where the denser the plaque, the safer it is, and coronary artery CT angiography. Those 3 tests together can give a good picture of your coronary artery status. And if you're in good shape, you certainly shouldn't be taking a drug that's causing side effects. One other thing to consider if you have to have statins is pravastatin, which has the cleanest side effect profile of all of the statins, to my knowledge, unless there's a newer one. And that's about all I can think. Oh yeah, and of course, normalizing blood sugars. One other thing. If your family history is of an elevated LP small a, there are a number of ways of reducing this. The most successful way is in women who have low estrogen levels. Estrogen replacement therapy can dramatically lower LP small a. And you could also search on the internet for means of lowering LP small a if that's very high. So, and that's, in my experience, the most potent risk factor in the blood of heart attacks. Just about every patient of mine, new patient comes in, has already had a heart attack before he sees me, and his LP small a is usually sky high. So one should look into ways of lowering LP small a, because that seems to be extremely potent with regard to atherosclerosis. Well, I think we've come to the end of our session. I thank you for listening. I want to remind you that our next teleseminar will be on Wednesday, October 26th, at the same time. take a look at Dr. Bernstein's Diabetes University. There are now over 100 videos and more coming. Lots of luck, and we'll talk to you in a month.